Hello, everybody. Thank you very much for joining us for our last webinar for NLAAD 2018. Today, the webinar is about co-infection, HIV, and hepatitis C. I am Luis Mares, the Director of Community Mobilization Programs at the Latino Commission on AIDS, and our presenter today is Paul Bolter, the Community Outreach and Education Manager at the American Liver Foundation. Paul is originally from Boston with over 25 years of experience in HIV, hepatitis C, and substance abuse field. Paul has been published in several publications addressing harm reduction and viral hepatitis, and most recently with International Business Weekly regarding the cause of the new drugs available for hepatitis C and barriers to care. Paul is dedicated to educating everyone on the facts of viral hepatitis, disease prevention, and access to care. Currently, Paul is the Community Outreach and Education Manager at the American Liver Foundation, Greater New York Division. Before we continue, I just want to let you know that all lines have been muted to avoid background noise. And if you have a comment, questions, or suggestions, please write it in the chat box on the lower part of the screen. And also, this meeting is being recorded. So here is Paul.
Good afternoon, everyone, and thank you, Lois, for having me today. It's an honor and a privilege to be part of this great effort. So I'm going to start off just by saying, at the American Liver Foundation, we're a national organization with 16 divisions across the country. I represent Greater New York, and my area is all of New York, parts of northern New Jersey, and going up towards Philly. So I am in a different borough, in a different class, a different setting every day, and in front of different people. And I really am amazed and sometimes surprised with some of the information I hear about HIV and Hep C separately or together. As part of our mission is to facilitate, advocate, and promote education, support in the research for prevention and the cure of liver disease. But I feel like we can't talk about liver disease without talking about HIV as well. So to me, they both go hand in hand. So we're going to start off with a little bit of basic stuff, and I'm sure some of you might know all this, but just for the sake, I kind of have to go through this. So the first thing we're going to talk about is what our liver does and why our liver is so important. Our liver is like our body's power plant. It performs over 500 different functions. So it filters everything that we put into our body, regardless of how it gets there. If we use a pill, a liquid, if we eat something, if we inhale it, if we absorb it through our skin like a patch, like Nicoderm patch or a pain patch, muscle creams like Biopsy and Bengay, all that gets penetrated through the skin. It all impacts our muscle. Sometimes we use the same products for many years and then develop a reaction to it. There could be a number of reasons, and sometimes it's our body saying, chemically we're not getting along anymore, so we may have to switch it up. Where a lot of people ignore that. They think it might be the product's expired or something else is going on. Our liver helps build muscles. There's good bile and bad bile. The good bile is what digests the food. Bad bile can create a little bit of a problem, and I'll talk a little bit about that. Stops cuts and bleedings, it kills germs, and it detoxifies substances that are harmful to us. And when I ask this question to people, I always say, what do you think that is? And the first answer is always alcohol. Every once in a while, I'm surprised pleasantly when someone says cigarettes, because cigarettes, we know, are terrible for our heart and our lungs, but they're just as bad for our liver. They don't get a lot of attention. It's, on the commercials, you don't see anybody complaining about cigarettes impacting their liver. But it does, especially if someone has HIV and hepatitis C. Smoking affects our whole body even more so because we're already struggling a little bit, and with a liver that's not working to its full potential, anything chemically that we're adding is only going to create some more stress. The liver is only about 3.5 pounds in weight. It's about as wide as a football, but it's not as big as a football. It's kind of like a chicken cutlet. I can't help but describe it that way. It's kind of got that squishy feel, flat feeling that sits right underneath the rib cage, and that's partially exposed. So when someone is doing an abdominal exam and you're laying down and your stomach is kind of sunk in, they're able to press on your stomach to see if your liver is inflamed or if there's anything else going on there. And, your gallstone is there, and, that helps some things too, but also you have to be careful with gallstones because if they travel into your bile ducts, that can create a little bit of a problem. So here, looking at our liver, we talk about the progression of disease. The upper left-hand corner is a picture of a healthy liver. So if you notice the color, it's pinkish, mauve, it's really smooth. You know, if I was to touch it, blood would just come out like as if it was a wet sponge because it's a filter. So the blood is filtering. The heart is pumping it, the liver is filtering it. So they work together. So if this was my liver, you know, my liver results, my lab results would probably say my liver function tests are unremarkable, meaning there's nothing to say, everything's great. Maybe I have a nice healthy glow, my skin, the circulation is good. Usually you can tell, you know, when you look at somebody how healthy they are, you know, that's a sign of a lot of different things. But then as time goes by, if my lifestyle changes, maybe my diet changes, maybe I start to be less active with community things, like maybe I don't go to the gym as much anymore, maybe I'm not going to my support groups, or maybe I'm not, you know, doing anything, say I'm just sitting in the house. You know, eventually I might gain a little weight, and, you know, maybe when I come in and have my vitals done for an appointment, you might notice this about me if you know me, and there might be some questions like, oh, what's going on? And if I'm reporting back that, you know, I'm just really not doing much and I'm just chilling at home, my cholesterol might be high because of my weight increase, and then my HDLs and LDLs. So when that starts to get elevated, chances are, you know, it could be from the excess weight, and I could start to develop fatty liver disease. So if you look at the second liver where it says it's moderately scarred with fibrosis, they shaved a piece of the liver off so you can see internally. And inside those bile ducts are starting to close because the scarring is starting to prevent the blood from flowing. So if you notice the outer piece of the liver, the color has changed. If you look at the top one, it's not as bright and pink anymore. So there's less blood, less filtration, and maybe there's a layer of fat that's covering it so that the bile isn't able to absorb. So if I'm on HIV medicine and I need to take my cocktail every day, and I'm really good, I'm compliant, I'm real adherent, and then maybe after a while my doctor might question me, say, hey, you know, are you taking your meds? I don't see any in your labs. Your labs aren't changing. And it's like, yeah, I'm taking my meds. I take them every day at this time. But what's happening is because of the fibrosis and any fat built up in the liver, I'm not able to absorb my medicines properly. So if I take a morning dose, great. Then my afternoon dose might not filter. Then by the time I take my evening dose, I have a pileup. So naturally, at the end of the run of the prescription, it's going to look like I haven't been taking it normally. And it might be because of this, but sometimes we're often accused of being non-compliant or non-adherent or whatever the issue is. And also, if we're struggling with our liver, we want our HIV meds to work. We don't want them to not be able to work together. So that's something that should really be paid attention to. So everybody that has HIV or Hep C should always have a liver function test done all the time with their labs. And the upper right-hand corner is a picture of cirrhosis. Now, this is not alcohol cirrhosis. If this was alcohol cirrhosis, it would look like a raisin, like a real purple piece of, like, you know, shriveled up meat, and it would have the same nodules, the bumps that you see on this. But this liver here is so dry that it's starting to break apart from itself. If you see the black cracks and the separating on the top, it's just falling apart. So there's no blood being filtered, and the medications aren't really doing much for this liver at all. This could be from someone that's been on steroids. It could be, you know, medication. It could be environmental. It could be a lot of reasons why this person has cirrhosis. But usually at this stage, it's either the prognosis isn't very good, or it could lead to transplantation, which isn't always accessible to most people. Thinking about how hepatitis C is transmitted, you know, we know it's a disease caused by a virus. You know, there's alcohol hepatitis, there's different types of hepatitis, but hepatitis C is definitely a virus that's transmitted from blood to blood. There has to be two pools of blood that come together. A chronic hep C over time can cause cirrhosis, like we saw in that picture, which is scarring. It could even lead to liver cancer or liver failure. Most people that have it may not have symptoms for many, many years. So they may not find out until they have liver cancer, or if they go into end-stage liver disease, and then they're in the hospital, and then someone thinks to run these tests, and they're like, oh, yeah, it's liver, you know, it could be this or that. Excuse me. Currently, there's over 3.5 million people in the U.S., and I say people, I don't say Americans, because this country is not made of just of Americans. It's made up of everybody. And there are people who haven't had access to screening. So there is still that population of folks that, for whatever reason, they're just not getting the care, they're not getting treatment, or they're afraid to. So they could be living with the Hep C virus and not know, and they could be, of course, subject to various types of liver disease. Hepatitis C is the #1 reason for liver transplant in this country today, and it doesn't seem to be changing, except fatty liver disease is catching up with it. So there are many causes of liver disease. Viruses, genetics is more mother to child, autoimmune, excessive alcohol use, diet, obesity, reactions to medications, street drugs, or chemicals. So a lot of folks that are using inhalers because they have respiratory issues, overuse of breathing inhalers could cause to cirrhosis and a lot of problems. They're very addictive, and a lot of people feel that they think they need a puff when they don't. They may lose their breath, or something could be going on when they're not training themselves how to breathe properly, or the person that's prescribing it isn't working closely with them. So they tend to keep inhaling, taking a puff when actually they don't, and that's just too much. They're overdosing on the inhaler. It happens very easily, especially with nasal inhalers, like over-the-counter stuff. And lots of medications, people are taking vitamins that don't need them. My motto is, if you don't need it, don't take it. Not every man needs to take the same vitamin. Not every woman needs to take the same vitamin. You should always ask your doctor first, because you don't want to have toxic reaction or liver failure as a result of that. In Hepatitis E Basics, hepatitis A, B, and C, these are the most common in this country. We are seeing a little bit of hepatitis D, but hepatitis D is very much like hepatitis A. And usually, some cases, the person that is positive both A and D. But we're not seeing a lot of it, but it is starting to show its face. Hepatitis A, is just like it says, how it's spread, food or water has been contaminated by fecal matter. It usually can last 3 to 6 weeks for some people if they're not vaccinated. Hepatitis B, it's like one of the #1 STDs in certain parts of the country. Blood and body fluids. If you look at it, semen, vaginal fluid, and saliva, there's many things that come in those contents. Unwanted pregnancy, HIV, STDs, you name it. And most people have a chronic infection. And without testing and treatment, it could also lead into liver damage. So there's vaccines for hepatitis A and B, but there is no vaccine for C. I don't even think there's really anything hopeful in the pipeline that I've heard lately, unless I'm wrong, but it's direct blood to blood. A lot of people say, well, what if somebody coughs on me? What if somebody spits at me, or if something happens, if I'm in a fight? And I say, if there's 2 pools of blood that come together, there's a chance. Sweat is not going to give you hepatitis C. There has to be blood to blood. All right. Who should be screened? Anybody that's used needles or other equipment to inject drugs even one time. Hepatitis C is 10 times more infectious than HIV, and sometimes some people think it's more to 15 times more infectious. There's a myth on how long it lives outside the body. So if I had hepatitis C and my blood was on the table, how long would it last? It's a controversial question because the answers could be from 3 days to 10 days. It depends on who you ask. So sometimes it's hard to find a consistent answer. So that's my answer, that it's kind of hard to really answer. A lot of it has to do with environment, temperature, and things like that. Excuse me. And we're working with needle exchange programs. I often try to remind people that it's great that they're using clean needles, but don't use anybody else's water. Even if they have your own cooker and all that, buy your own water. Find your own source of water, because the last thing you want to do is stick your needle into someone else's water. It's great that you're using a clean needle. I celebrate that, but don't use anybody's water, because it could just take that one time that you could be at risk for transmission. Baby boomers were, the main target of all of this, but I have to tell you, and I know a lot of people will probably agree, that reports are increasing number of new infections among young people ages 19 to 29. The heroin epidemic is in every community. Everybody across the country is struggling with how to best address it. But the young folks are now starting to take the spotlight away from us baby boomers. And it's been a few years, but people have only talked about it maybe the last 2. And I just think the numbers are going to continue to rise with that population because the baby boomers are aging out. I'm a baby boomer, I know. So it's changing. If someone's HIV positive and they got HIV from blood to blood, of course, anybody that's HIV should automatically be screened for HCV. If I'm a healthcare worker, like I said, needle exchange, or if I'm doing phlebotomy, or whatever I'm doing that involves needles, and if I get stuck, I need to take immediate action. Go to the hospital, go to emergency, go wherever you have to go, get a screening, and then prepare to be screened again because you're not going to know your results at that one time. And blood products and organ transplants before 1992, the blood banks and the organ banks were really not in good shape, but things have supposedly gotten better. But I will say, if someone is born to a hepatitis C infected mom, their risk is less than 5% of transplant to the baby. So also hemodialysis, it's not a comfortable way of life. Sharing straws for cocaine or other drugs, especially like crystal meth, any drug that's really rough and abrasive on the sinus cavity, creates that mucus and the people sniffing that they might not see the blood, but the blood is there, and it could be on the straws, the dollar bill, whatever they're using. Tattoos and body piercings. I waited many, many years for my first tattoo, and the first thing I asked the artist when he was setting up, I said, "Oh, you taking nice universal precautions for HIV?" He said, "No, I'm worried about Hep C." And I was pleasantly surprised to hear him say that because it's what I do, and that he knew what hepatitis C was, or he knew how to take some preventative measures. So I think in a lot of the artists that I've spoke to, they are on top of that a little bit. There's still room for some more education and community partnering, which I think in all our cities that have tattoos, we should be doing more of that. In multiple sex partners and STDs. If you have multiple sex partners, chances are someone's going to end up with an STD. And, there's no shame, and, I'm not going to beat up anybody that had an STD, but if I know they have another one right away, there's other conversations that have to happen. Do you understand what safe sex is? What does safe sex mean to you? Find out what they know and then build on that by providing information about PrEP and condoms or abstinence or whatever they need to work around that. Having sex with someone with Hep C is extremely low risk. There has to be blood to blood. So sometimes it could be traumatic sex. And what is traumatic sex? It could be jailhouse sex. It could be using toys and not cleaning them and sharing them. Our bodies aren't made for certain things, and when we use them, it causes some trauma. So it could tear some linings and stuff like that. So if the toys aren't cleaned, that could be a little bit of a risk. Sharing personal care items such as razors, toothbrushes that may come into contact with infected blood. So when I had Hep C and I would shave my head, if my brother came to visit, I made sure I never had like a razor laying around my bathroom because I wouldn't want him to use it to shave and then maybe cut himself. So things like that. Going to nail salons, bring in your own equipment. Don't leave it there. Take it home with you. And be careful getting a pedicure. Don't let them cut your foot or shave your feet. Just got to be mindful of some of those things because besides Hep C, you might get other types of infections. Going into the Hispanic and Latino population, I've struggled with this for a while, and fortunately I'm able to partner with the Latino Commission on AIDS to get some really good direction because there's not a lot of appropriate current data because, there are so many different countries, and some countries based on political or socioeconomic or even anybody paying attention to what's going on. Sometimes the data is it's old. It's 5 years old, 6 years old, and it's not fair to use that data because it doesn't, represent, the people from those areas appropriately. So I'm really careful about what I use. And I was able to find out, that there are approximately 52 million Hispanics and Latinos in the U.S., right, which is 16.7% of the total population. With the rate of illicit drug use in the recent months, Hispanic individuals 12 and up was 8.9%, while the national average was 10.2%. And the rate of binge alcohol use among Hispanics and Latinos was 24%. And this is like the bulk of like a lot of information that's out there. And it seems kind of like, well, what does this have to do? But a lot of times some of the messages are, well, because of substance abuse, because of alcohol use, because of drug abuse, people are putting themselves at higher risk. Yeah, but that's across the board. Everybody does. I don't think there's one race over or culture over another that is, more prevalent with that. But the information is so askew that it's hard to find really great current data. Fortunately, this little bit of information I was able to get from SAMHSA, but it really just focused mostly on alcohol and drug use. So testing and screening is really important no matter where we live. Here in New York, I was fortunate, along with the Latino Commission on AIDS a few years ago, to help work on getting the screening mandate, which is state law offering screening tests of people born between 1945 and 1965. So what was happening was the doctors in all the hospitals were getting a pop-up on the EMR while they were with the patient. And the pop-up would be like, did you offer this patient screening? And sometimes the doctors or whoever, maybe not just the doctor, whoever it was, might ignore it because maybe they felt that the patient wasn't at risk, or they didn't want someone else influencing how they treat patients. So sometimes, they were missing patients. So it does get used. There are a lot of providers that are behind it. It's taken some time because it's new. And if a patient doesn't present or doesn't share certain information, the provider might not know to ask, might not know to figure out if they're at risk or not. So other states such as Massachusetts, Connecticut, they have mandates. States have recommendations to screen are California and Colorado, but there hasn't been like a mandate set in. So this is something that really needs to happen a lot. And always, I tell people, don't assume your patient's not at risk because we don't know people's history before they come to see us. So if they tell you, yeah, I'm fine, I'd probably ask a few more questions. So testing, diagnosis, antibody test, which is just like the HIV test. That same company makes it. It's a finger stick. 20 minutes later, you find out if you've been exposed to the virus. I tell people, it does not mean you have full-blown HIV or Hep C. That's why we need to do a viral load test, which is a confirmatory test to see how much of the active virus we have in our system. Sometimes it's really low, sometimes it's untraceable, and sometimes it's substantial enough to say you definitely have a positive diagnosis. With hepatitis C, there's genotype testing, which determines what type of Hep C you have. And that's going to determine how you go forward with treatment considerations. And in this country, genotype 1 is one of the most common, and 1A as well, which tends to be a little bit more resistant to treatment. So back in the day, people used to have to go in for a liver biopsy in order to get treatment, and I'm sure a lot of us have heard, no way am I going in and having a 12-inch needle stuck into my side. It is a very large needle. It is very uncomfortable. It's very scary, and it does look like that, a little brown piece of spaghetti. It's like a 3-hour process. You're not allowed to leave for 2.5, 3 hours after it, and you have to lay on your side. And I'll tell you, if you're just getting clean and sober and you're just trying to catch up with things, all of this is really overwhelming information. And then to have to figure out, I have to go in and have a needle stuck in my side. I can't tell you how many people have refused to come into care because of this. And then every 5 years it has to be repeated. So now, in the last few years, we've been blessed and fortunate to have we have the FibroScan, which is this machine here. It's like a $35,000 machine. Not every hospital has it. And the copay could be up to $350 for people with insurance. So a lot of times the doctors that have this in their office, if they know the person is on like Medicare or something, Medicare probably won't pay for it, so the doctor's office will absorb the cost because it's 99.9%. They would rather do this. It takes 20 minutes, if that, and all you do is lay there, and that machine that you see in the picture, the guy presses the button, it clicks like a pen, click, 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 and it sends a magnetic wave to your liver, and it vibrates off your liver, and it comes back, and it shows a number, a score on that screen, and that tells you the density and, what type of condition your liver is in, what the fibrosis might look like. And then with labs, it's a great way to treat people. And I'll tell you, more people are more likely to come into treatment knowing that there's this alternative over the biopsy. Some doctors still insist on doing the biopsy. It is the gold standard. But everybody has a different outlook. And I'll tell you, more people will get treated if they know they're not going to get stabbed with a needle. You know, there's a lot of different treatment options. We see commercials all the time on TV. I think the commercials are good. I'm glad that they're there, but I know I don't look like anybody in those commercials. And a lot of our patients don't look like people in those commercials. So, and they're often on at times where not everybody's watching TV. But they are great. It's better than nothing, and I commend the company that does it. But, you know, you have to think about the whole patient, not just the gender, not just the age, not just the mentality or the, you know, the socioeconomic. You have to consider the whole patient when thinking about treatment. Because, first of all, you know, if the person has Hep C, we want to test them to make sure there's no other liver damage. And if we scare them or if we treat them in an indifferent manner, then we're going to scare them away from treatment, and we're not going to go any further. And we won't find out what their genotype is. We won't find out what their pre-existing conditions, and if they've been on treatment before. You know, if they're new to treatment, they're treatment naive. If they've been on treatment prior, they call it experienced. And, you know, people that are experienced may be experienced because of other issues that have happened that may have interrupted their treatment. It could be life issues. It could be the drugs just weren't appropriate. But working with direct-acting antivirals is it's replaced the interferon, so that whole chemo effect, that whole weekly injection, that anemia, the constant fatigue, a lot of that is gone, dehydration. And, you know, everybody's going to be treated differently based on your genotype, based on your HIV status. What is your HIV status? Are you undetectable? Are you infectious? Are you having issues with your numbers? Are you, you know, what is going on with you? And some people that, you know, have gone through the medicines that don't work, there are also clinical trials that people are able to participate in that have shown some great results. And not all treatment options are the same. So the new medicines that we're talking about are pills. There's usually 12 weeks. If someone has HIV, if they're co-infected, depending on a few things, it could be six months of treatment instead of 3. And the side effects are very minimal: fatigue, headache, rash, anemia. You know, many of the new treatments, people may have a slight headache or not at all. Some people live their lives like nothing is going on because the drugs have given them that sense of freedom, and, you know, the drugs work. The patients in the doctor's office a little bit more. Usually they're in the first week, second week, third week, fourth week, and then the visits are spread out because it's only 12 weeks of treatment. So within a week, they'll notice if the viral load has moved at all, and they'll be able to determine if the drugs are taking any effect. If they're not, they're just going to pull the patient from treatment. They're not going to stress the patient out by taking it for the full 3 to 6 months if it's not working, because they don't want to build up a resistance, because they may need to be used in combination again later for the patient if they don't do well in that. Multivitamins along with taking medicines. I tell people again, you know, if you don't need it, don't take it, because the vitamins could have interactions with your medications. And, you know, women are more common to be anemic than men are. So a female patient could take an iron pill, and that might help with their anemia. But men, we shouldn't be taking additional iron because it could affect our prostate. We could develop prostate cancer. And, you know, sometimes if we are anemic, the doctor may prescribe you iron, but it would usually be for like 30 days, a specific amount, no more, no less, no longer. And then when you're finished with that course, they would take your iron levels, and once you're back to normal, you discontinue the iron. So, you know, if you're taking a multivitamin, make sure what's inside it, bring it to your doctor, or just, you know, ask somebody that knows, a nutritionist, a nurse, somebody that has some experience. And treatment's been very successful. I was diagnosed in 2001 with hepatitis C, and I was treated 8 times over 16 years before I was cured. So treatment is very different. Success is very different for everybody. It's not always the first time out based on what drugs are available. There are drugs that were out 5 years ago that the company is no longer existent. They come and they go, and I think, you know, they're making great progress. So the goal is to have an SVR, which is a sustained virological response. If I had HIV, I would think that my goal would be to be undetectable. So SVR, undetectable, there's so many similarities between the two viruses that some people could get a little confused, because if I say I'm undetectable, what does that mean? If I have a sustained virological response, what does that mean? And they mean the same. They mean the chances are you're undetectable if you're, if there's no trace of it, or if your viral load is sustained. So the SVR means it no longer can be detected in the body 3 months after the medication. So for Hep C, it's at 3 months. So after the 3 months, if it's not detectable, that's great. But then a lot of things could happen. After the end of the 3 months, the patient is sent home and they come back 3 months later. So we're talking really about 6 months. And in that 3 months that they're gone off treatment, they could relapse. And it could be medication that could relapse. Maybe the medication just didn't stick with you. They may get reinfected based on behavior. They may use something that had a little blood on it that may have caused them to be reinfected. So things do happen. But if they come back at the end of that 6 months and the virus is still undetectable, they're considered an SVR, and they're also given the cure diagnosis. And by genotype, that's going to differ. So, and also if there's any liver damage. So if genotype 1, which we know is more common, the cure rate's 85 to 99%. With interferon, it was like 45 to 65%. So already there's like a massive difference. Cure for genotypes 2 and 3 is a little bit more better, 95 to 99%. And genotype 4 is up to 100%. Now, prior to not too long ago, depending on what genotype you had, depended on what drug you got. Well, now, fortunately, there are drugs that treat all genotypes, so nobody's left out. There are times where patients have said, well, we can't treat you yet, or we're not going to treat you now, you don't need it, or there are lots of different things. Some patients didn't really need treatment because they had no liver damage, they had no fibrosis. So it was okay if they waited a little bit for effective treatment, as long as they knew what precautions and how to take care of themselves so that they didn't, cause their disease to progress. And and as a result of people, being made to wait or not being able to get treated, now, fortunately, the companies have come out with drugs to treat all genotypes, so nobody's left. And if, like I said about the co-infection, they may go on 6 months, but there's a lot of stories. I mean, there's a lot of other implications that come with folks that are co-infected. The CDC says that, among HIV-infected individuals, Hep C is estimated at 25%. It ranges from 10 to 30% in MSM, men with sex with men, up to 80-90% in people with heavy drug use. Co-infection more than triples the risk for liver disease, liver failure, liver death, for a lot of different reasons. It could be medication, lifestyle, health, disease progression, a lot of different things. And antiretrovirals may slow the progression of liver disease by restoring some immune function. And another thing about that is that people that are on hepatitis C medicines, if the medicine doesn't work, whatever course they were taking helps slow down the progression of the disease. So any treatment is better than no treatment. So even though the patient may not be cured from the drugs that they're on, at least while they were on the medication, the disease progress was slowed down. And it would help, build up, their immune system gets stronger. And so there is some benefit. I mean, nobody wants to be uncured, but that's one way of how the progress can be slowed down. So living healthy with Hep C, this is different for everybody. We try to make sure everybody's at the right doctor. Are they at a gastroenterologist, a hepatologist, an infectious disease? Is the nurse practitioner or the RN they're working with, trained? I mean, if it's a general practitioner, a lot of general practitioners now want to be able to treat their Hep C positive or co-infected patients, and there's trainings available, which is great because if you live in a rural area and there's only one doctor and you have to travel 2 hours, it's going to be tough. It's hard for the person physically, emotionally, and spiritually to get there. So it's great that whatever doctor you get to, you find the right one. And then ask about other screenings, get liver cancer, any other complications from your Hep C. How is your HIV doing with the medication you're on? Has the patient been vaccinated for A and B? A lot of people don't know. A lot of people, vaccines weren't available when they were in school. And it wasn't until they enter college where they find out that they have to have the vaccines. Or our parents, if our parents aren't born in this country, maybe they weren't offered them wherever our parents come from. So we want to make sure that our parents and family members are also screened for hepatitis A and B. Try to be compliant. I always say no more holidays. I think, for a long time, holidays were a thing that was done on a personal choice with the patient and the doctor. But with some of the hepatitis C drugs, you cannot afford to take a holiday. If you skip doses, you may be pulled off treatment. It's really important. The drugs are extremely toxic and powerful. We want the drugs to work, so it's a short enough run of treatment. But if you think you really need to take a break, please discuss it, have an open, honest conversation, and make the decision together. And try to follow a healthy diet and address any substance abuse issues. Now, this is different for everybody. Active substance abuse can greatly diminish your chances for curing hepatitis C. There's just no way around it. You have to be careful. If abstinence is recommended or harm reduction is recommended, you have to figure out what's attainable and what the person can manage or handle. It means something different to all of us, so we have to kind of be respectful and culturally sensitive as well as compliant and competent with whoever we're working with, because it's not one drug fix all. So additional treatment, HCV progresses more quickly for those who are HIV positive, like I said, so access to treatment is especially important for folks with co-infection. So going into access to clean injection, a lot of folks in New York were, and I'm sure across the country, were being denied treatment because of their substance abuse and use. So they were considered extremely high risk, and nobody wanted to treat them. So there was a group of patients that were treated for the hepatitis C. They were engaged in a needle exchange program and supportive services, and a group of these people were able to stay compliant and be adherent on the Hep C treatment. And, a couple of them cured the virus. And they were injecting drugs, but they were injecting drugs with clean needles. They were in safe spaces where if anything happened, there was somebody there to help them. They had clean water. They had, just a support without being judged for who they are and what their behavior were. And they tended to have successful treatment. So we know that mandating 6 months of sobriety or anything like that is really not always necessary. And people with co-infection are just as likely to be cured by the DAAs as people with hepatitis C alone that are mono-infected. So as we come close to an end, just some more about SVA rates are 95% higher than have been reported. The clinical trial regimens of people co-infected with both viruses. Even for those who were not cured by previous and who had advanced fibrosis, there is still a chance for them to obtain a cure diagnosis. Antiretrovirals are broken down by the liver, so in turn, prescription drug liver toxicity is more common with co-infected because the toxicity levels of the medications, depending on the person's liver. If the liver is weak, some patients depend on the kidneys to filter medicine. So there becomes this little game, on what medicines can we give you that won't overdo your liver, but we want to treat this and this. And how scarred is your liver? Are you cirrhotic? Where are you with your disease level? So that's going to determine a lot about how the people respond. Most people with HIV know to have their liver enzymes checked regularly as well. When we go to the doctor and they draw our blood, they're not checking liver enzymes or anything unless there's a specific reason. We always want to make sure we say, how are my liver function tests? Have you run my enzymes? We want to find out because in those tests they could see other liver problems caused by HIV or other drugs, and they need to address that right away. Overlooking anything that might be weird could be harmful later. And Hep C treatment, like I said, earlier, the risk of liver toxicity is lower, and it slows down or even stop the scarring. So although the patient may not be cured at that moment, they're at least seeing some salvation to the disease state of their liver. HIV treatment and prescription drug interactions. I think a lot of people know that some HIV meds can interact with Hep C medications, which decreases the effectiveness along with serious side effects. So in turn, some HIV and Hep C medications should not be used at the same time, or dose changes should be made. So this is really tricky. In my experience working with co-infected individuals, somebody may be undetectable for the very first time. They could be long-term HIV positive patients, and they finally found a drug that's been working, and they're undetectable, and everything is great. And to say to them, I'm sorry, but that particular drug, doesn't get along well with the Hep C meds, so we're going to have to switch it. It doesn't go over well. That's usually really difficult and controversial. So it's like something that has to be worked on in a group, the provider, the patient, support system. And ultimately, the decision is up to the patient, but everything should be very transparent on why do we need to change your meds. Yes, you're undetectable. It's amazing. We want you to stay undetectable, but we also want to cure your liver disease. So, there's that reluctance, and the patient should not be left alone in that decision, but ultimately, it's up to them, and it should be respected, whatever the decision is. So to wrap up, we know there are more than 4 million people in the United States expected to be chronically infected with Hep C. Most people, like 75%, are undiagnosed. That's a lot of people. The second most common reason for liver transplant. Many are unaware of their infection, worse liver-related outcomes, and it spreads the disease 10 times faster than HIV. And that is it. Again, I want to thank Luis and the staff here at Latino Commission on AIDS for this opportunity, and thank you all for bearing with me for the last 40-plus minutes. Thank you.
Thank you very much, Paul. So now we open the floor for questions, suggestions, comments. You can write it in the chat box. Yvette Gonzalez is asking, is it harder to cure hepatitis C in people living with HIV compared to negative people?
Not always. I think if the patient has, low liver disease, like, F score of 1, meaning fibrosis, if they're in good shape, and their liver is good, working well, and, there aren't any other factors, why can't somebody be treated? Sometimes it is 6 months, but, sometimes it's just the 12, so it shouldn't really matter.
Andrew Hollinger says, can hepatitis C virus be treated if the patient abuses alcohol regularly, and does it matter if they are HIV positive?
Well, the first part of your question is a good part, Andrew. If someone is abusing alcohol, they should not be starting treatment for the hepatitis C, in my opinion. I had postponed treatment for a lot of individuals after doing an assessment, and I asked them about their drinking, and they answer it one way, and then when I come back to the question and I ask it again, I ask them, oh, you have 1 beer a day, can you show me what that beer looks like? And when they show me with their hands, it's more like a 40 or a 32 ounce, and to me that's like 2 or 3 beers a day. So that's probably not a great candidate for Hep C treatment, because we know how alcohol impacts medication, our kidneys, and everything. So we need our kidneys to work good if our liver is compromised. Our kidneys are going to filter things that our liver can't. So it's probably not recommended for that, but if the patient is drinking and we don't know, we'll find out during the first couple of visits, and then they'll probably be taken off treatment, whether they're HIV positive or not. And if someone's HIV positive and they're abusing alcohol, they're going to have some issues as well. The drugs aren't going to be as effective, and we could see some negative stuff happening for them as well. So,
any other question?
No, thank you, Andrew.
And Yvette also.
Thank you, Yvette.
From Puerto Rico.
Oh, thank you. It's good to hear from. My prayers and thoughts are with you and everybody in Puerto Rico every day. There are people here that are thinking about you and praying for you, and we love you too. So just know that.
Any other question for Paul? While you guys think about questions, I just want to thank everybody who has attended the 6 webinars, or some of the 6 webinars that we have had for NLAAD this year. As I mentioned at the beginning, this is the last one, and we will have soon webinars again for NLAAD and again NLAAD the next year. So thank you very much for having us, for joining us, for sharing everything with us. So, questions for Paul?
Fernando, why would you take off therapy and create resistance? Maybe why would I take somebody off the therapy? It could be because they're not managing the medication properly or the medication isn't working. Not all the drugs that are out there are going to be suitable for everybody. So if we see that the medicine's not working, instead of having them continue to take it, it's not doing them any good. It could do them more harm. And if they're drinking, the medicine is just clashing with the alcohol, and they're just going to waste it through their body. And like any medication you take, if you're drinking alcohol, it's really going to be ineffective. It's not going to see any results because the alcohol is so strong, and the way everything metabolizes in the liver is, the liver can't handle alcohol as a whole. It shocks the liver cells. So just drinking alone. I think where it create resistance is if the person continues on it and it's not working.
I think what he wants to ask is like, if I'm a patient and I need treatment for hepatitis C and I'm drinking, and I start treatment for hepatitis C and then you realize I'm drinking and then you stop treatment, wouldn't that create resistance? Wouldn't I have resistance?
Not if it's stopped, because if someone stops you for that reason, then it's usually early on. So there hasn't been enough of the medicine in your system really to even be effective. So, if you wait, like if you're halfway through the treatment like you're asking now, I'm going to see what is your viral load? Is the medicine working? How's your HIV viral load? Because now, being co-infected, we're taking a couple of different medicines and now we're drinking alcohol in a way that we shouldn't. There's a lot of factors. And it's a safety issue too, because the medicines for hepatitis C are they're very strong. And if we combine them with something that could be harmful, the effects could be damaging. So I would see where the patient is. I would check your viral load. I'd probably try to give you some support around your drinking and say, if the meds aren't working well, we're going to have to stop you because, your drinking may be having this impact on you. Is it up to the doctor's decision? The doctor's discretion. I would hope that the doctor would have open communication with the patient, and the patient would feel safe enough to have this discussion. People don't want to be shamed because of their drinking or drugging. So, there's a lot of things to take into effect here. It's consideration. If I know that you're my patient and you're struggling with drinking, then maybe we should have had this conversation before we talked about treatment. Or while we were discussing treatment, we were both completely sure that this was going to be effective and that there weren't any chances of being non-effective. Some doctors won't even start you, on treatment. Like I said, they might make you stay sober 3 to 6 months, and that's not always fair. If the person's a social drinker, I don't necessarily think that that's going to have a huge impact, but social drinking means something different to everybody. If you're talking about the hepatitis C drugs, I don't know if it's really one is stronger than the other because some of them treat genotypes differently. Certain, before the new drugs out, the medications each, like one treated genotype 1A, 2, 3, 4. So they were different classes, different combinations, different drugs. So not everybody could take them. So if you were one of those genotypes and there wasn't a drug available, you had to wait. I waited 3 years one time for a drug to take. So, and then being HIV positive, that has a little bit of a impact on it as well.
He's agreeing with you.
Oh, okay. Thank you. Thank you for those questions, Fernando.
Any other questions for Paul?
Fernando, where are you calling in from? Oh, okay.
From the Bronx.
The Bronx.
So that's good in New York City. Well, if there's no other question, we will finish. Thank you very much. In the heart of the epidemic.
Absolutely.
Thank you very much, Paul, for giving this information about hepatitis C and HIV co-infection. And I hope to have you here again for when we have NLAAD.
I hope so.
Thank you very much, guys.
Thank you.
Have a good weekend.